Perfect.
Dear audience, I welcome you to another educational session. Today, our topic of discussion is about laser treatment in glaucoma. Yes, we are talking about selective laser trabeculoplasty and pattern scanning laser trabeculoplasty. How these treatment can decrease the dependence on topical medication in glaucoma patients. And in order to discuss this, we have invited today Professor Dr. Francisco Suni. He's a glaucoma specialist in Hospital General Matthew Orfila, Menorca, Spain. He has got almost 15 years of experience in glaucoma management, and his practice mainly focuses on medical, laser, and minimal invasive glaucoma surgeries. And he has special interest in photobiomodulation and neuroprotection in glaucoma diseases. Currently, he is doing a leading clinical research line on pattern scanning laser trabeculoplasty. So he is basically integrating laser therapy, neuroregeneration, and targeted supplementation and photobiomodulation in glaucoma management. So we are thankful to Dr. Francisco that he has accepted our invitation to educate our audience on this very important topic. Without further delay, I will request him to please present his talk.
Let me know.
Yes, sir, please.
Okay, Dr. Alim, thank you very much. I'm honored to be part of these sessions, educational sessions. I'm so happy to share my experience, that 15 years of experience with selective laser trabeculoplasty. All of them, all kind of them. The first selective, the actual pattern, and the direct selective laser. We are trying to focus not about to overheat the trabecular meshwork, but this new concept of photonic immunomodulation. First of all, the first part is to have in mind two questions. Who of you in this moment are prescribing topical hypotensive drugs as the first line therapy for even ocular hypertension or newly diagnosed open angle glaucoma? And the second one is, and most important, who of you are offering laser or SLT as the first option? Because if we see the people in the world, the key opinion leaders, they are saying that we are reaching late the treatment of the glaucoma. We are operating the patient when it's too late. So if we let the time go on, the glaucoma gets hard to treat, and we start to see more difficulties in the cornea and the epithelium of the conjunctiva, and over that, all the treatments, surgical and laser treatments, are with the outcomes are going down. So small, very short history. I think that all of you know about it, but in the 80s, it was the beginning of the first line of the trabecular stimulation with the argon laser therapy. That it was about 1 decade of improving, but the operator was the most important part of the treatment, because if you miss one shot, you had this bleeding, inflammation, scarring, this damage. So when it appears, accidentally they discover Latina and collaboration investigators, and they found this selective laser stimulation or photothermolysis, selective photothermolysis. They know that, they figured this out, that not overheating with low doses of laser, they reach the same function of the trabecular. It was the beginning of a new concept. 5 years later, they had this approval from the FDA. They know, and they find that we can repeat the treatment 1, 2, 3 times as we need it. And after that, we start to have these huge reports of 3 to 6 to 7 years of follow-up with the light trial. And the last one is the Glorious from the European Glaucoma Society, that when they study many years in many centers and hospitals from London, the direct SLT. The importance, the main parameters that we had in mind is not the power, it's about the fluence and the exposure time. Because if we move from milliseconds to nanoseconds, we reduce the exposure 1,000 times in every impact. So if we calculate that with the SLT, doesn't matter which one of the three of them, we are using 6,000 times less power than the first technique. So same target, completely different physics, because we are not anymore depending on the operator, because we are stimulating all the width of the trabecular meshwork, about 400 to 500 microns. In the first picture, up and left, we have the scar, the huge crater of the argon laser trabeculoplasty, and in the middle, we can see a completely normal trabecular meshwork, because after this photonic stimulation of the laser, we are more close from healing, more closer to healing that damaging the tissue of the inner part of the eye. We can use any kind of them. They are all excellent equipments with a small difference. Some of them have this display, and we can set all the power, the size, the spots, the number of spots. But the important is that we are reaching the trabecular meshwork from inside with the SLT and the PSLT, and in the right. The parameters are now the important. So this is not about energy, it's about stimulation, because we are going from selective photothermolysis, targeting the granules of melanin with a special neodymium jack in that wavelength from nanoseconds. And look at what really happens inside the eye is that this absorption is so selective that stimulates and produce that biological response, recruiting the macrophages, extracellular matrix remodulation, cytokines, immunoglobulins. What is the outcome? The outcome is not a damage and a scarring. The outcome is that we improve this outflow, and we are healing and repairing the trabecular meshwork. The past 2 decades show us that 20 to 40% of IOP reduction we can get from this only one procedure treatment, with a success rate close to 90%, from 60 to 95, depending on the cases, and we can repeat it 2 or 3 times with no damage in the eye. So we don't have any change in the morphology. It's safe, and we early indicated we better response we had. I'm going to show you in a moment the results of our investigations. So I think all of us know when to indicate and not to indicate a selective laser, but I prefer to take it in mind. So primary open-angle glaucoma is the first indication. If they have pseudofoliation or pigmentary glaucoma, it's a very good option. We need to reduce the power, but anyway, it's the best option. I also indicated in ocular hypertension. It's the same if it have phakia, pseudophakia, or aphakic eyes. It doesn't change the outcome. I also indicated a lot in pregnant or young ladies that they are looking for getting pregnant. So this is taken in mind. Of course, in patients with redness, allergy, and keratitis or conjunctivitis for the eye drops, this is another great option. So when you should avoid the laser indication, in that patients that ask for only one treatment with never anymore needed to do any kind of thing. It is impossible. You have to explain them that it's the best shot. You have to do it, but perhaps you need a retreatment or supporting another eye drop or another surgery. I shouldn't indicate it in a maximum treatment medical tolerance, because if they don't respond, they will not respond to the laser. Please indicate surgery, okay? When they have clear indication of trabeculectomy, and when they have neovascular glaucoma. Practical tips: what do you have to know about the outcomes? If you indicate it early, please, early is the disease, higher rate of success, because what we saw in our studies is that the keratitis, conjunctivitis reduces the outcomes of the reducing the intraocular pressure. Why does it happen? I don't know, but I guess that if we give to the patient 20 years of eye drops, now the laser will not work as well. Please read the angle pigmentation. This morning, I made 8 PSLT at the hospital. One of them was the worst pigmented angle I saw in my life. So I reduced the power to about a third of the normal I use. Pigmentary glaucoma, drop the power. This is the same. PX pseudofoliation. It's not the same as pigmentary, but take care of, reduce the power. Retreatment. When we retreat, please reduce the power. There are studies that say that when you make the second time, it's better than the first time, but don't use a lot of power. Take care that the non-responders to prostaglandins should perhaps they are also non-responders to the SLT. So what it's all about, the European Glaucoma Society, that they say that the laser should be the first line, because the laser reduce the intraocular pressure, reduce the progression, and reduce the rates of surgery. So laser trabeculoplasty may be offered as the first line treatment for open angle glaucoma, and the level of recommendation is strong. And so let's come back to the first question. If we know all of this, why the drops is still the first option? Can you think why? Okay, we are so familiarity. We have so familiarity with the eye drops. We know that the eye drops works. Okay, the equipment is really expensive. Okay, I don't have. I'm not comfortable with the laser. You should think about it, because this is not the future. This is the present. This is the best for the patient. And a commercial asymmetry, I will not go in there. You should try to figure this out. So from the SLT to PSLT, I have experience in about 500 treatments of SLT in Argentina, and now we are going to reach the 200 patients with PSLT in Spain. It's the technology is really close one to each other. It's really low operator dependency, because you can see in the right to the top to the bottom, the size and the width of the spot is the size of the trabecular meshwork, so you cannot miss the shoot. It's amazing. A big difference is with the SLT, I should do 100 shots, the 360 degrees. With the PSLT, in 60 seconds, I made 32 spots or shots, and it's quite more comfortable for the patients. So we now have a lot of experience of works that talks about the experience of the patient and what happens or what's going on with direct DSLT. It's the new technology. We need more time to know about it, but what would we know? To the right, Glorious trial. They had a lot of patients, about 200 patients with a nice follow-up, and they show that they find that they have no difference with the SLT in the reduction. So non-inferiority margin was met, okay? In 12 months, they have the comparable IOP reduction. And I'm sorry, something important. I told you before, the DSLT, it's 3 seconds treatment, no contact with the eye, no gonio lens. It's like a topographer. it's quite magic. So the work we are going to present in London, it's our investigation, our research with, by now it's 140 patients, half with 1 year follow-up and the other half with 6 months follow-up with the reduction of IOP. But mostly we find that, this is a secret by now, but we found that the more damage the cornea, is lower the outcome of the treatment. So in real world practice, that we find it's about about 50% of the patient became completely free of treatment. We're talking about patients with three, 2 or 1 eye drops. 67% reduces their glaucoma medication. 95% reach the success rate of reducing about 21 millimeters. This is quite amazing. This is the same with another presentation, but it's the same investigation. What is this concept of photothermolysis to photonic immunomodulation? I wrote this article in the European Ophthalmology Times Europe, presenting this theory of what are we doing when we stimulate the trabecular meshwork. So with ultra low energy, we anyway have this stimulus. So this is not a microdisruption. This is a trigger of the trabecular meshwork cells. We are touching the nerve of the stimulus. So we restore the immunomediation response, recruiting the macrophages, all the inflammatory cells, starting signalizing and cytokine-driven regenerative pathways, and we start to remodulate the extracellular matrix protein. So this is the future. So about the cascade of immune activation, we are going to see that we are producing this triggering of the photonic triggering with this really low light stimulus, with the signaling of the inflammatory response, activation of the cells, and restoration of the outflow. We are healing the trabecular meshwork. We are healing the eye. What is my blow mind by now? The therapy of the future is not just lowering the IOP, is using all the things we have in with the artificial intelligence and all the bots and all the agents we can put to work with us. Okay, we should lower the IOP. Yeah, it's perfect, but we should to restore the trabecular meshwork, the trabecular function, with stem cells, regeneration, photonic immunomodulation. We need to be serious about neuroprotection using all of the proteins, peptides, amino acids that we have now. I'm leading another investigation about that. I'm crazy about that because it's really amazing. About precursors of molecular precursors and supplements. This is what I told you about citicoline, nicotinamine, and nutritional support. We need to heal the patient, not to reduce the intraocular pressure. We need a healed patient, okay? And photobiomodulation with red lights and infrared and near infrared. This is our last investigation. A few ideas to take home, please. SLT works. The light study at 6 years show us that the 70% no need more medication, or they didn't get the surgical instance. About the European Glaucoma Authority, we have a strong European Glaucoma Society. We have a strong recommendation of laser should be the first-line therapy. PSLT is the same. They match the SLTF efficacy with better tolerance and less aggression for the tissue. We are not looking to produce the champagne bubbles. We are just touching the eye. It's amazing. The SLT, it's quite expensive. It's not superior, but we have it in mind. We should have it in mind. Perhaps in 5 years, all the clinics will have one, and with no medical operators. We have this series next Congress presentation that will reach a huge amount of patients medication free with reducing of the burden as economical as inflammation and everything. I'm so sorry. We have a 1 year progression, 1 year follow-up shows that there is no difference between the 3rd, 6th, and 12 months. Our frontier, we should be looking forward, like not just reducing intraocular pressures, but inducing neuroprotection and photobiomodulation. That's all for now, and thank you very much.
Well, Dr. Francisco, it was a very interesting presentation, and you mentioned the importance of SLT and PSLT. But still, the question comes in mind, why still anti-glaucoma drops are the first choice when we have such effective treatments available with us?
Okay, this is a good one, because in my practice, we still see many colleagues using this technique. We are prescribing eye drops since we were fellows or residents, and the company is visiting us, and they have these courses. So this is not a problem of if works or doesn't work. This is not a tool problem. It's a mindset problem. If we put our energy in the patient, if we start to see the outcomes with laser, we are not avoiding or forbidding the eye drops, but we are going to start using more this stimuli of the trabecular meshwork.
Well, you have a lot of experience about PSLT and SLT. So when you are picking up the patients, which one are best suited for SLT and which are good for the PSLT?
Okay, this is hard because there is not a big difference. This is not a big difference, but I started 14 years ago using SLT, and now I moved about 95% of my practice to PSLT. Why is that? Because it's a matter of time. As I said in the presentation this morning, I made 8 treatments, about 60 seconds each one per eye, 60 seconds with the PSLT, and the patients don't feel nothing. They are like, that's it? Can I go now? Can I drive? What should I do? And that's amazing, because when you perform a SLT, you are looking for the champagne bubbles, and you're producing some kind of inflammation. This is not just light. This is a laser working hard on the trabecular meshwork. And when you perform a PSLT, I mean, DSLT, you don't see what happens, but in the PSLT, the pattern, you touch the trabecular meshwork and you don't see nothing. There's not widening, there is not bubble, there is nothing. It's just the light working on. It's amazing.
About photomodulation, photonic immunomodulation, and your concept reframes SLT as a biological therapy. What is this concept as you're saying about, I'm mentioning it as a biological therapy, this photomodulation?
Okay, this is quite disruptive. This is one of the reasons that is going on, all the industry trying to reach this new kind of investigation, because this concept reached the the idea of I start treating the eye, trying to reduce or elevate the power, trying to produce some kind of response with my changes. But it's if I think that the patient is the important, the body, the immunity of the body of the patient is important, I just produce this stimuli, and the immune system of the body starts the response. So it's not on the operator, it's not on my experience, it's all about the immunity of the body. We have images, new images of the trabecular healing and working with the heartbeat. It's not a structure, a fixed structure of like a wall. It's not a wall, it's not a net, it's a live tissue. So if we stimulate it, we can heal it and it start to work again.
Right. So with now AI technology coming everywhere, how do you see the future of this lasers in glaucoma management?
This is interesting because in the past 5 years, the change was huge, because the appearance of the direct SLT was like, this is serious because we are not even touching the eye. We don't use the gonio lens. You don't have to be a doctor. You just need to touch a button and in 3 seconds. So I think that we are going to have these kind of protocols, new protocols adapted to the automatized gonioscopy with AI that would say this age, this gender, this from Africa, from Europe, from US, or from who knows where, this patient needs this adapted protocol of treatment. So I think it will be like completely personalized.
Well, Dr. Francisco, it was a very interesting talk, and you have answered all the questions in great detail. It was a pleasure talking to you, and I hope it will be very beneficial for our international audience. I want to thank you on the behalf of our international audience, and I believe it will help them a lot in their clinical practice. Thank you, Dr. Francisco.
Thank you very much, and congratulations.